Thank you. Hey, I'm Bill Mex. I'm a general surgeon. I've lived in Alabama all my life, trained at UAB and then subsequently at Caraway, where we had the medevac for 5 years during my training. And so I've seen a lot of septic patients, but it wasn't until 2011 I had clinical practice in general surgery for 25 years at Keller and then came to the VPMA position around 2010. And it wasn't until 2011 we got a septic patient in the hospital, and the septic patient came in and was seen in the ER, discharged, came back the next day and died. And I became interested in this population of patients and came to this understanding that I really didn't know much about septic patients and how sepsis kills. And so that's what we want to talk about in the talk today, how sepsis kills. And I probably can't teach you much about that, but we've been working with the Sepsis Initiative since 2011 at our institution. That's when the process began. And we've had a reduction in mortality rate by 50% in a small hospital that doesn't have much resources. And so we've gone from a 22% death rate to a 10% death rate. We've been involved in a national cohort. We helped develop the core measures for sepsis with the Joint Commission. We were one of 5 hospitals in America. I volunteered the hospital to enter into a cohort with CMS and Joint Commission, and so we're part of that pilot. So we've had intimate contact with CMS and the Joint Commission related to the core measures for sepsis. So if you're mad at the core sepsis, they glean some of that data from us. So we have 185 beds. We see about 40,000 people a year. And so we want to look at how sepsis kills. The doctors at our institution, the gray-head doctors, they don't really understand the pathophysiology of how sepsis kills you. I did not understand that. And once we understand the pathophysiology of how sepsis kills, we'll be able to embrace the treatment plan for it. So that's what we've done, how to diagnose and how to treat. So how does sepsis kill? This is a case that we saw up in New York prior to my time of coming on as VPMA. This young child died from sepsis, small scratch on the arm, came into the pediatrician, discharged, came into the ER 2 days later, discharged with multi-organ failure and presented dead and cardiovascular collapse in about 2 days. And so we had a lawsuit up in North Alabama with a young child who died from sepsis, very similar case, died from sepsis. The jury was hung jury. They settled between $1 and $3 million on the case. And so we tried to move legislation through Alabama back in 2012. We have 2 Alabama senators on our staff, and then we saw that this was going to be a core measure. It was going to be a national core measure, so we dropped that legislation. We wanted everybody in Alabama to be screened for sepsis in the ER. Have y'all seen one of those yet? No.
You can't get a patient left the country in the last 30 days.
Okay. But 50% of your patients admitted to the hospital are septic. So let's start screening for sepsis so we can identify that population. And so that's what we're trying to do. So we activated this back in 2012. And here's some general facts. There's probably 1 million people diagnosed with sepsis every year, and a quarter of those die, 250,000 deaths. And here's the financial impact, and I thought it was astounding. Half of everybody dies in the hospitals from sepsis, either primarily or secondary. $24 billion a year, 21% of all hospital charges are related to sepsis. It kills more than breast cancer, colon, pancreatic, prostate, all combined. We have campaigns for all of those, but we've had very few campaigns about sepsis. MVAs, 1 in every 13 minutes dies from a motor vehicle accident. Sepsis, 1 every 2 minutes. That's in America today. And so who does it strike? There are 19,000 baby boomers every day, so we're going to see more sepsis because it strikes the old and it strikes the young. And so we have a huge aging population. We have more people immunocompromised today with immunocompromising drugs, so we're going to see this increase. So how does sepsis kill you? It causes tissue damage, organ failure, and death. And we want to go through the details of the pathophysiology of that. So if we understand the pathophysiology, we can understand how to treat the patient. This is one of the key slides. This is a slide I did not understand well. I didn't understand why you get a trauma patient within 5 minutes. As a trauma patient, you have a white count of 18,000. I didn't understand that. That's a systemic inflammatory response syndrome. We have demargination of the white blood cells. We have the inflammatory cascade begins, or systemic inflammatory response system. And so this cascade really was well identified in the Vietnam study when these young boys got shot. They came in, they got a good operation, they were rescued within an hour. They got a good operation, they ended up in ARDS, and they ended up in renal failure, and this population died because we failed to get proper perfusion in these patients. And so sepsis, we all got it. I know you need antibiotics, but you have to restore perfusion in this patient population. There's a redistributive shock in sepsis patients, and we'll go through those details. But you see here, The white blood cells activate the inflammatory cascade, and the inflammatory cascade is what kills us. It's not the bacteria. We're giving them antibiotics, right? You're still seeing septic patients die. So you saw the Ebola patient in Texas, the person, the healthcare worker that got Ebola virus, they did not turn a hair. The guy that came back from West Africa died with that. Missionaries died with that. Why? Because it's early diagnosis and early intervention, and the key that we don't understand is we have to get perfusion in this patient population. So we've got to get over the obstacle. They got heart failure. We've been doing this since 2011. We have not drowned anybody. We have not drowned one patient. And so you have to give this patient populations to stop this inflammatory cascade. So hypoperfusion causes continued tissue damage. If you had continued tissue damage, you continue the inflammatory process. And so that was that patient population I would take to the OR, perforated diverticulum. I get a drop in the blood pressure because they were poorly resuscitated, and guess what that does? That activates the inflammatory cascade again. SIRS is reactivated. And so the leukocytes and the tumor necrosing factor, they go everywhere in the body. They cause vasodilatation, they cause endothelial damage, and this process has to be stopped. So we're more at danger from the inflammatory cascade. The old guys like me, inflammatory cascade, SIRS. This was discovered and understood to some level in 1972. So now we get to the dumbed down surgeon picture. Bacteria, white blood cell have a fight. They have an inflammatory cascade or SIRS, and probably the chief offender is tumor necrosing factor. Vanderbilt's done great work with tumor necrosing factor, but you can't pick out the population who is septic. So there's no magic bullet yet. So tumor necrosing factor is released. It causes a systemic reaction in the cardiovascular system and in the coagulation system. And this is kind of a slide out of critical care medicine. So what's the impact? What is the impact in the cardiovascular system? First, you get vasodilatation, nitric oxide is released. It's a potent vasodilator like a nitrate. Also, you have lack of vasoconstriction, and you have systemic endothelial damage. This is a thermonuclear event, and it cascades through the entire body. So you have activity, you have endothelial damage, vasodilatation, and throughout the whole body. You get it in the brain, you get it in the lungs. And so the crossover piece of data that helped me was, we all know about ARDS, right? You get a whiteout in the lung, right? You get failure to perfuse. You have an AA gradient. You can't get oxygen in because you have a thick membrane because it's leaky. The same thing happens in the brain. When you get septic, you have a whiteout in your brain. You have a whiteout in your kidneys. You have a whiteout in your lung. You have a whiteout in your heart. Why? It's systemic. And so the leukocytes, tumor necrosing factor, they injure every epithelial lining in the body. And so this patient population comes in, and part of the problem with this vasodilatation is the first element. And so we touch this patient population and they're warm and dry. Why are they warm and dry? Because they vasodilate. We think cold and clammy is dangerous. Early sepsis patients are warm and dry. Their systemic vascular resistance is reduced to 400, so they have a redistributive shock. And if we don't understand that, we won't have confidence about giving large volumes of fluid. So we have leaky membranes, endothelial damage. Now, what's the effect on the cardiovascular system we just talked about? What's the effect on the coagulation system? So we know that endothelial damage activates the platelets. And so you not only have leaky membranes, now you have microemboli. So have you ever seen that patient that comes in with a urinary tract infection that has altered mental status? We've seen that. So why does grandma have altered mental status? She has leaky membranes. She has cellular hypoxia. She has microemboli in her brain. That's why grandma is confused. And so if you had a person with a plastic bag over their head, you'd help them, right? Grandma has a plastic bag on her head. She is having cellular hypoxia. That's what that altered mental status is. So you have this whiteout everywhere from this endovascular injury. So we have to stop that, and we have to make this disease a time-sensitive disease. As a gunshot wound's 1 hour, as a heart attack's 1 hour, sepsis is 6 hours. We have a 6-hour bundle. Yes, sir.
Does Medicare allow you to identify altered mental status in their severe sepsis identification?
You are the doctor. Are you the doctor?
Last I checked.
You got the Rook card, and if you diagnose,
I call it severe sepsis, but
that's right. We code it as metabolic encephalopathy secondary to sepsis or severe sepsis, and that's good enough for the coders. You got the last say-so, doc. And so we're the one practicing medicine, and that's how you diagnose it. So you have a urinary tract infection, and they come in, they have altered mental status. It's severe sepsis with you have to link it with altered mental status secondary to urinary tract. They cannot hurt you with that diagnosis. That is the proper diagnosis. So yes, you can. And we actually have used hypoxia too. So if you have an O2 sat in our institution less than 90 or require increasing O2, we consider that respiratory insufficiency / failure. You can't use dysfunction or insufficiency, you have to use failure. And I'll show you a case where I'll just tell you, we had an ENT surgeon who had a prostate biopsy on Wednesday, came in, required 4 liters of O2 to maintain a blood O2 sat of 90. 36 hours, he was septic from gram-negative E. coli sepsis. That is respiratory failure, and I don't have any problem writing that on the chart. So that's a good question. So microemboli, leaky membranes, whiteout everywhere. So it affects 2 systems primarily. We had a patient in not too long ago who had a retroperitoneal hematoma with MRSA, had a cardiac ejection fraction of 60% on admission. 2 days later, they had an ejection fraction of 30%. So what's happened to that patient? Vasodilatation, lack of vasoconstriction, leaky membranes, microemboli. Are you telling me that hurt their pump? I'm telling you that hurt their pump. They dropped their ejection fraction by 50%. And now you begin to see how the systemic effect of organ dysfunction. And so you get a patient in that's not treated, and who gets called first? Respiratory pulmonologist gets called because now they're on the vent. And who comes in next? The nephrologist. It's always bad when the nephrologist comes. Is there a nephrologist in here? It's always bad when they come. And so what we've done is we got the antibiotics, but we did not stop. We did not get adequate perfusion. And we allowed the inflammatory cascade to run. SIRS continued to run. With cellular hypoxia activates the inflammatory cascade again. So here's a cheat sheet. This is a cheat sheet slide we have before lactic acid. Myself and the pulmonologist are probably the only 2 guys in the hospital that knows what the anion gap is, and I'm embarrassed to tell you as a surgeon I even know what the anion gap is. But I've studied that and learned what the anion gap is. Where the anion gap goes, so goes lactic acid. And so you have an easy way on a CMP to see if a person's sick. You can look at a CMP. If their CO2 is low and their anion gap is up, it's time to say, time out, this person is sick. If that is mediated by sepsis, that patient population is sick. And so that's what we do. We look at that and go, we get an alert on that patient. CO2 down, anion gap up, you better pay attention, somebody's going to die on you. So that's what we do, try to get a timeout on that. Now, we've been in this process since 2011. We became overzealous about diagnosing sepsis at our institution. Remember, the 4 tops are only perfusion markers. They do not have specificity. They are not specific for sepsis. You can have a patient in cardiogenic shock who has a lactic acid that's elevated. A person with exacerbation COPD, heart failure. So part of the team approach is, I have a patient in septic shock. Tell me where the infection is. Well, they don't have an infection. Their lactic acid is up. Time out. Where's the infection? Everybody on the team has the right to ask where the infection is. So we've got a heart failure patient in not too long ago that we missed the first box on the screening tool. Infection or suspected infection, and they got 4 liters of fluid, and they had what is it?
BNP.
BNP.
Yeah, BNPN.
Yeah, they had 38,000. They were in volume overload, and they got another 4 liters. And so we missed the first step of, does the patient have an infection or suspected infection? This is about a year into the project. We overtreated the population, so remember, those are not specific, and they're seen in those other entities. Now, case study. Now, I do have we're in the process of a transition. They have changed the diagnosis of sepsis. I don't know if y'all have seen that data. I brought it for you, that you can have it. The third definition of sepsis occurred back in February. And so they've changed the definition from sepsis without organ dysfunction, sepsis with organ dysfunction, and septic shock. They've changed it back to what we understand. What is that? Infection, uncomplicated. Sepsis always is indicative of organ dysfunction, and septic shock, those patients who failed fluid resuscitation. So they got the definition back. The problem is CMS is not up with this third definition change. And so I have a draft of our screening tool change, but we haven't got it through P&T yet. We had a fight at the last P&T meeting. So we've had a reduction of 50% in our mortality rate, so I'm a little bit circumspect about changing the screening tool. So that's where we are in it. So under the old system, this person would have a diagnosis of sepsis, 2 SIRS, pneumonia. They would have a diagnosis of sepsis without organ dysfunction. I don't think that's a good definition, but that's where we are with CMS right now. So you can be septic without being bacteremic. That patient that came in with a decubitus that died, I naturally, as the smart surgeon, asked to see the blood cultures. The blood cultures were negative. Therefore, in my book, you cannot be septic. That is not right. 50% of all septic patients are not bacteremic. So that's another thing. You know, medicine is changing, right? We kind of discover new things as we go. So I had to take that one down. So we can have associated organ dysfunction, and here's our organ dysfunction. We ended up in the pilot with the Joint Commission, and we had 2 elements that are not in CMS, altered mental status and hypoxia. And so we kept that because it broadened our net to pull in that patient population that we need to pay attention to. So this is our screening tool, and it's in yours. And so this is what we presently screen with. This is not Survive Sepsis campaign data, nor is altered CNS Survive Sepsis campaign data.
My only issue with that was the creatinine of 2. If you have an 86-year-old lady with a creatinine baseline 0.5, she comes with a creatinine
That's
of
right.
1. Previously, I had to identify that patient as severe sepsis. Like you said, I call it severe sepsis regardless of the creatinine's 2 or not.
Right. The system's not perfect. I mean, the last thing that just came out, all patients with a lactic acid greater than 4, the infection or suspected infection are by definition defined as septic shock. And so that patient's to receive a 30 cc's per kilogram bolus. And so the ER group of the United States does not agree with that data. And so they're in a fight. But that's how CMS is going to measure us. They're going to measure us on a 30 cc bolus in anybody with a lactic acid greater than 4. So this is one of our staff members that volunteered for this project. He had a prostate biopsy on Wednesday right after MEC, and here's how he presented. 36 hours later, these are his vital signs. He was operating on Wednesday morning, and he came in septic shock. He had a blood pressure of 80, lactic acid greater than 4, creatinine. He had 5 organ dysfunction. And I'm glad we had septic protocol in place. He did well. He ended up with 4 liters of fluids, a little vasopressors, and was discharged in 3 days. This patient, under resuscitated, will end up in respiratory failure on a vent, and they will end up with renal failure if we do not intervene with adequate fluids.
Do y'all do SVO2?
Pardon?
SVO2 monitors?
No, we have gone to the perfusion data. We monitor our patients in sepsis and septic shock based on the perfusion data. So we use 2 parameters: perfusion, i.e. blood pressure, i.e. urine output, and we reserve central line, central venous mixed O2, central venous lactic acid for a subset of patients that we do not understand where the volume status is. So we went through the Survive Sepsis campaign in 2012. We educated everybody in the ER. We brought mannequins in. We bought an ultrasound for the ER. We got everybody up to speed. But when the process data came out, we don't have to do CVPs and mixed venous O2 and all that. So we moved to the process data. That's a good question. So this guy, we're proud that we were able to do that. When I started this sepsis initiative, I went back in the chart. We had an orthopedic surgeon that was operating with me one day, and he would go into the bathroom and have a GI bleed, and he would go operate. And he would go into the bathroom and have a GI bleed, and he would go operate. And then he came into the doctor's lounge and passed out. And so we took him and scoped him. He had a bleeding diathesis of his stomach. We thought he had ulcer disease. He had a cut on his leg that he'd been treating for 2 weeks. Excuse me.
I like him better already.
He had a cut on his leg for 2 weeks, treated himself with steroids, anti-inflammatories, and undertreated with antibiotics. He was transferred to Vanderbilt and died. He was 50 years old. We have had 2 MDs come in sepsis and 1 nurse practitioner come in sepsis in our institution. This is serious. And so what happened was I had a patient back in 2012, an 18-year-old child that died from sepsis, and we really took the chart to MEC, and we said, we're going to take good care of this patient population or we're going to ship them. And we have the ability to take care of this population. It takes some work. It takes a cultural change in the hospital. And so we decided at MEC level that we're going to inculcate and we're going to have a robust sepsis program in this institution. And so that's what began this process of us become robust. Now remember, when you have a robust plan for sepsis, it is the number one death killer in your hospital. It's the number one. If y'all are non-cardiac here, right? It is your number one killer. It will improve your survival rate, number one. It will increase your case mix index by proper diagnosing. It'll decrease your length of stay. We abstracted data. We have decreased our length of stay by 3/4 of a day, which equates to over $1 million. And it will reduce your risk for liability. You know, once we have a core measure, this is free game, right? This is free game. And you don't hit the bundles, we're all going to be in trouble. I have been sued 2 times. I would not wish that on my worst enemy. I got sued by a bad drug. You've seen the bad drug ad, right? I got sued as a general surgeon for a bad drug called a bowel prep. That's the bad drug. That cost me 5 years. I was in that litigation for 5 years. And so I don't want anybody to say, hey, I didn't know how to treat sepsis. We know how to treat sepsis. We need to hit the bundles. We need to do the best we can. Everybody's not going to live, but we need to save those people that we can. Here's the guy's mortality rate. He had 5 organs dysfunction. His mortality rate was 60%. He was operating 36 hours before. We lost an orthopedic surgeon with sepsis. You're on the clock. Now, let me look at this real quick. This is how we activated the program. We got accepted in a Joint Commission Center for Transforming Health. I volunteered. Why did I volunteer? Because I could not get traction with the sepsis initiative. We couldn't get traction. We tried and tried, so I volunteered for this. I know that seems crazy to volunteer for the Joint Commission to come in and help you, but we did. We volunteered for that. They gave us the bundles. The original bundle with the Joint Commission is we had 1 hour for antibiotics and fluid resuscitation. So that data was very tight that we participated in. So we came into that. We had the best data of the 5 hospitals in the cohort. There's only been 10 hospitals piloted in America that have participated in developing CMS guidelines for this. And we're one of those hospitals. So, as a physician, I don't like you to give me a solution if I don't think there's a problem, right? I am the doctor, right? And so what we did was we presented cases. We looked at our institutional mortality rate. I do not know your institutional mortality rate, but I will tell you our institutional mortality rate for sepsis is 10%, and it's one of the best in the country. We had a reduction in mortality rate at Keller Hospital, a little hospital that's broke like y'all are, hard, grumpy, old doctors like y'all have, and we reduced our mortality rate by 50%. And so if we can do it, you can do it. And it makes me proud to do it, you know. I'm not going to let the government take the joy out of taking care of patients away, for crying out loud. That's why I go on mission work every once in a while. You know why I go on mission work? Because I want to just go take care of a patient. And I want to see them smile and be happy and take care of them, because if I don't, I forget, because the government beats us down so bad we lose the joy of medicine. We went into medicine to take care of folks, right? It is fun, right? We got to get back to that. We got to get back to the fact that we like medicine. So we created essentially a moral crisis in our hospital. I'll tell you how I did it wrong. I taught the ancillary nursing service before I taught the doctors. And so all the nurses got educated, and then they're looking at the doctors like, what's going on? So I had to pull the whole program back again because I overran the physicians. So we took this to MEC. We decided institutionally that we should do this. We developed a quality council. The quality council has moved into clinical initiatives in the hospital. We have moved our peer in quality council to clinical initiatives. The wellness does with the drug rehab and the behavioral problems. I don't want to deal with all that. I want to deal with clinical initiatives. So that's what we do at the quality council. So we developed a plan. We brought forth a solution. If you tell me I need to do something and you force me into the system, I'm not going to like you, and I'm not going to be happy, and I'm not going to sign and time and date your chart. Doggone you, I'm not going to do it. But as we captured these doctors with ownership, we ended up with a robust sepsis program because we like to fix stuff. And so we take this to the quality council. Here's the national data. Here's our data. How can we fix it? And as the VPMA, I facilitated order sets, bundle sets. I brought my son-in-law in for education. He's a pulmonologist intensivist at LSU. He came in and gave education, and we'll see that. He came in and brought us up to speed on 2012. We gained a few champions there. We saw the 20% reduction only with early goal-directed therapy. He came back and retrained us in the process data. We continued that education through the ED department. The ED department was the worst at our hospital. They were resistant to this. I fought them the worst. The pediatricians were second. I picked up 4 medicine guys and 2 surgeons that became my champions that began to move it. And what happened in the Quality Council, it's not an administrative movement. It is a peer movement. And so I got multi-specialists in the peer movement. Therefore, I got surgeons and medicine doctors driving everybody. It's not the administration telling us what to do. That's a force in. I don't want to force in. I want to buy in. And so we got these docs to buy in, and then we abstract our data and say, hey, every month we're seeing a reduction in mortality. And we present that at MEC, we present that at all the department meetings. So we gave encouragement to that. So I went around, taught everybody, all the committees. I did a lunch and learn. You know that screening tool? I'd go out in the community, do a lunch and learn with all those old folks. And you know what I did? I gave them a sepsis screening tool. It's really dirty. And I told them, hey, ask your doctor if you're septic. And I said, but don't use my name. Please don't use my name. So we kind of had a coup in the community. So we began a community education process. And so they started coming in with their little protocol sheets. So we implemented this. We took all the screening tools, all the bundle order sets. We took it through all the committees, P&T, critical care, all the departments approved, and then we implemented it. We started the process. We looked at time 0. We got the screening tool. I have the draft of the new screening tool in some of your stuff. Don't use it yet. We're still working on the draft. This is a screenshot of the computer. Took me 1.5 years to get this in the computer. Good grief. How long does it take to get this in the computer? Finally got it in the computer. You can't get through the computer until you do that. And guess what? It still didn't work again. You know, that's really frustrating. I would much rather be a surgeon and put you to sleep and cut you open and fix it. This has been a terrible project. So we had to regroup. We had to come back. And here's what we did. We took the ER charge nurse, the ICU charge nurse, chief CRNAs, and we put them all in a room. And you know, they don't get along, right? ERs don't like the ORs. Everybody's fighting all the time. So I divided them up and put them on the same team. Somebody from the ER, somebody from the ICU, and somebody from the OR. And I put them on the same team, and we did education, case presentation, and they had to tell me how they're going to take care of that patient. And they're going to have to tell me what hour they're in and how they're going to pass off the patient. And then, here's the breakthrough.
I'm up for that.
This is a painful initiative, I'm just going to tell you. And so we got all this summarized. We got all this summarized in bundle sheets. Here's all you got to do. This is not hard. Antibiotics before the blood cultures, before the antibiotics, measure lactic acid, fluid resuscitation. I will put a disclaimer on the 20 to 30 cc's for severe sepsis. This is not CMS. This is our institutional best practice. This patient population that is not hypotensive but has perfusion markers is telling you they are hypoperfusing. So that patient population we resuscitate. All you got to do is get another lactic acid if the lactic acid is greater than 2. It's not hard. It's just laying processes in place. Also, the perfusion note down here, we made a deal with the ER. You got them 3 hours, you're responsible for the perfusion note. What did they do? They whined and griped. They don't want to do it. Too bad, you're doing it. MEC, we all came together, everybody agreed. You got to do the perfusion note. And if you miss one element on the perfusion note, you miss the whole core measure, right? I didn't make the rules. I'm just telling you the rules. If you miss capillary refill on the perfusion note, right, ladies? I see some nodders back here. You miss the entire core measure. So it's something we have to dot our I's and cross our T's on. That's the perfusion note. I won't go back. This is where we broke through with the ER doctors. They agreed to do that. I just had a breakthrough about 2 months ago. We had this, septic shock patients that come in. Now remember, if you're hypotensive and you get a fluid bolus and the fluid bolus brings your blood pressure up to 120/80, you by definition are not in septic shock, right? It's only the people that fail the fluid bolus, i.e. 30 cc's per kilogram, bolus over an hour, you remain hypotensive, then you start vasopressors and you continue fluid resuscitation. That patient is by definition in septic shock, right? If you pass the bolus, you're not in septic shock. And we agreed institutionally 2 months ago that that patient who is in septic shock, who requires vasopressors and additional fluids, be seen in the ICU within 1 hour by an MD. That only took me 4 years for that to happen. They want me to come out and see the gunshot wound, right? But they don't want to come see a septic shock patient. So we fought through that and we've got that passed. So we're excited about making progress. And this is just little steps over and over. Here's our order set. That's our antibiotics. Remember, the core measures for pneumonia stop, and we have core measures for sepsis now. Here's ours, core measures, antibiotics. You cannot use these. Disclaimer, this is a condition of our antibiogram. And so you have to figure out your own antibiotics, but these are CMS guidelines. This was a fight. Notify MD urine output less than half a cc per kilogram, blood pressure less than 90. Those are our two perfusion elements. If you quit peeing and your blood pressure is less than 90, some doctor needs to be cognating on that case. And so they all fought. They fought it. I don't want to get the call. Sorry, we're either going to take care of the patient or we're not. That's what we signed up to do, right? We signed up to take care of patients. And so we fought through this. We fought through the C1 hour. It's a whole fight. It's just a fight. Here's the breakthrough. ER nurse. You know what this is? This is the worksheet. If you come into our hospital and you get diagnosed with severe sepsis or septic shock, we have this worksheet. This is about the 5th draft of this worksheet. I made up the first draft. The nurses have fixed it since then. So you see blood pressure, urine output, you ought to see some activity down here below it. You shouldn't see repeated blood pressures low, repeated urine outputs without some activity. And so here's where we got a breakthrough. The charge nurse in the ER is responsible for every sepsis patient. They're responsible. And the nurse who has that patient is responsible. They have to sign the note, and they have to tell me who it goes to. I review every sepsis patient in the hospital that has a missed bundle element or who dies from sepsis. And I want to see that we had progression of these. So we have spent the first 6 months sending out FYI letters. Hey, you missed the diagnosis. A better way to code this would be so-and-so. Your treatment was good. But after 6 months, these go in your quality file. Do you know it's a condition of participation for CMS that if you violate core measures, you get a quality note that goes in your file. So we just sent out a letter to all the doctors. These will now go in your quality file. If you have missed bundle elements, and so we've had one physician who had multiple missed bundle elements, and he came into FEPI for cause. And so we isolated him. We made him take additional training in sepsis. He's admitting to ICU. Now, how did all this work? It didn't work from administration. It worked from the peers. The peers, the other medicine doctors and surgeons, says this is not okay. We are not going to let people lay up and be under resuscitated in this patient population. So he came into FEPI for cause. I finished 5 of his charts. He's out of FEPI for cause now. So he's back out of that. So they know that the Quality Council is looking at all this chart. So it's produced an institutional tension that helps doctors perform better.
Do you have a similar protocol for like post-op patients that get septic?
We
or
do.
Patients that
We have a sepsis watch. And so if you have a patient, and I had to go to the recovery room and teach everybody, status post-appendectomy, that patient is still septic in recovery room. It doesn't mean Dr. Mekas did something wrong. The patient's still septic. And so now they're on septic watch looking for organ dysfunction. And so we have a sepsis watch in that patient population. Yes.
What about patients that become septic on the floor
We have,
after they're admitted from someone's office? Or
that's our third limb. So we've done the ER, which is going to constitute 95% of your septic patients. Post-op OR, then direct admits. That's what we're working on right now. So we have that same screening tool that they're going to have to go through in the computer on the floor. So typically, if you have from a doctor's office goes to the floor, that patient is typically not going to be in shock or severe sepsis. Typically, but we do have some. And so we're training the nursing supervisor to pick up that population and just say, hey doc, this patient's positive on screening tool for severe sepsis or septic shock. They need to go to the unit. Then I can get them into the protocol in the unit. So, all right, so we do quality counsel. We review cases. We review cases every month in quality counsel. Not only has this helped us with our sepsis initiative, but the quality counsel has helped us with other clinical initiatives. We started a blood initiative last year. We've had a 50% reduction in blood utilization in 1 year. And we had 50% of our blood used at our hospital 2 years ago was for hemoglobins greater than 8. We have dropped that in 1 year. That is, not only is that those patients don't get a liquid tissue transplant, right? That alters your immune system forever. Blood's not good for you. And if you see who hangs out at the blood bank, it ain't good for you. And so we have reduced our blood utilization by 50% using this quality counsel and peers. Do we still have some outliers? Yeah, we have some outliers. And so we did a blood order set. You can't order blood at our institution unless you write down the hemoglobin. And if the hemoglobin is greater than 8, you have to write down cognition why you're going to give blood out of national guidelines. You don't think that wasn't a fight? Yeah, that was a fight. But look what we did. We reduced our blood utilization. That's $500,000. 3/4 of 1 day length of stay in our institution on the septic population, that was $1.2 million. That's what we saved, not to speak of the lives. And so the Quality Council has helped us move things through. We've developed a screening tool for MRSA infections and C-sections. We put a screening tool at 36 weeks. We have sepsis initiatives, an infection initiative in the OR, where if there's an infection, everybody on the team is interviewed to see what broke down where. And so the Quality Council has helped us move through because they're caring for clinical initiatives. And a lot of the meetings we go to, they're kind of crummy, right? But if we go in, it's the Quality Council, we're looking at clinical initiative, everybody likes that. So we present the problems to the doctor and they help facilitate that. Reduction in mortality, we share the results. This is what we did. We put a board up in the hospital to look at our results. We took the data from 2013, abstracted the data pre-order set, pre-screening tool. We had a 20% mortality. Then we abstracted the data into 2015. We abstracted that data and it was like 36 lives saved. And we're like y'all, we live in a small town. We know these people. We don't want somebody dying on our watch. And people are going to die from sepsis, right? But the terminal patients, that's probably an easy way to go. And we don't feel bad about that. But we don't want young people dying from sepsis. There's no excuse for that. We do a bracelet. Where's my pack? I was going to give you all a bracelet. Hey, hand those out. Here's what we do. We developed a bracelet. These are the sepsis colors, black and red. And so when you get a septic patient, the nurse gets a bracelet. And when the nurse passes off that patient, they give that bracelet to the next nurse. And they say, not on my watch. You're not dying on my watch. And so we give that patient the bracelet when they go home. A sepsis survivor, Helen Keller Hospital. So we get a free ad, right? So it's an easy way. It's just a good reminder to how we do that. Here's our mortality data. So we started out about 20%, and that's probably 5% below national average. National average is 25%. So we abstracted 5 ICD-9 codes. We didn't come up with it. The Joint Commission told us what codes to abstract. So we see a reduction in mortality rate. We're less than 10% per month, that's as good as Kaiser Permanente. That's a big thing. And look at the number of patients we've diagnosed. Back in 2014, we diagnosed 494 and 562. Look where we were back here, 281. We're just the same population of patients. They just went out and recognized. And so you can see in 2014, we diagnosed right at 500. We went to 562. We had 87 deaths of 500, and we dropped it to 60 of 562. That's a 10% reduction. So we just didn't increase the number of patients we diagnosed. We increased the number of patients we diagnosed, and we saved lives. So everybody in the hospital knows about this. It's on our little TV that we've been part of the Joint Commission process of that. We're presently working on disease-specific certification. We want to try to be the first hospital in Alabama to be disease certified for sepsis.